Hello, good afternoon and welcome back. I hope you feel refreshed after the lunch break. Now, the UK has larger geographical differences than many other developed countries on multiple measures, including productivity, pay, educational attainment, and health. Good health is just as important in spreading opportunity, contributing not only to the economy, but also ensuring that everyone, wherever they live, can enjoy fulfilling, happy, and productive lives. Strong public services not only support positive health and educational outcomes, but also attract new talent and investment to an area, boosting local economies. By 2030, the gap in health life expectancy, or HLE, between local areas where it is highest and lowest will have narrowed, and by 2035, HLE will rise by 5 years. By 2030, wellbeing will have improved in every area of the UK, with the gap between top performing and other areas closing. That is the goal, at least, but how do we get there in reality? In this panel discussion, we try to understand the current position and how we collectively close the divide, given that there is presently a strong link between deprived areas having poor medical support versus affluent areas having better medical services. So welcome to our panelists, James Freed, Chief Information Officer for Health Education England. He's passionate about digital literacy and the professionalism of health informations and across the health and care system. He trained as a molecular biologist for several years before making the move to process redesign and IT. James worked in hospitals in Southwest London for the Cancer Services Collaborative. He cut his teeth on national IT implementation following a move to NHS Connecting for Health, where he worked in pathology, order communications, and prevention, screening, and surveillance. James moved to the Health Protection Agency, where he managed an operational information management department. He then became head of information strategy at Public Health England. Tim Cullinan, Deputy Director, NHS England. Tim is part of the NHS England Digital Care Models team, leading the digital health team. He works to increase the number of people supported by technology-enabled care at or closer to home. He's worked in the NHS for over 15 years in a range of roles, including in care homes, operational management, commissioning, consultancy, regional and national teams. Tim has a passion for reducing health inequalities and working with people, patients and healthcare professionals to improve outcomes. And Nick Worth, Deputy Leader of the Council and Portfolio Holder, People, Places, Economy, South Holland District Council. Nick has been a South Holland District Councillor for 16 years, 12 as Deputy Leader, and currently holds the Economic Development Portfolio, which covers infrastructure, inward investment and skills. Nick is also an executive member on Lincolnshire County Council with a portfolio covering heritage, culture, libraries, registrars and coroners services. Nationally, Nick sits on the Local Government Association Safer and Stronger Board and is an LGA accredited peer mentor. And John Ford, clinical lecturer in public health at the University of Cambridge and co-lead of the Health Inequalities Pillar at Cambridge Public Health. John is an academic public health doctor and clinical lecturer at the University of Cambridge and Queen Mary University, London. He has policy experience within local government and local, regional and national NHS. He had recently led the development of a Levelling Up the Health framework and review of the previous cross-government health inequality strategy. And lastly, Richard Roberts, Chairman of the Health and Wellbeing Board at Hertfordshire County Council. Welcome to you all. Gosh, we've got such a wealth of experience here. I don't think half an hour is going to be enough to mine your expertise, but we will give it a go. I'm just a reminder to our audience watching, do submit your questions if you'd like to ask James, Tim, Nick, John or Richard anything at all. So, gosh, I don't even know where to start. There's so many wonderful areas to cover here. Nick, let's start with you and talk about the main issues in your area, the main health and wellbeing issues there.
Yeah, well, I think the main issues they've been around for quite a long time around obesity, cardiovascular disease, just basically lack of physical activity. Trying to get people active has been a big issue for us for a long time. Mental health is also quite an issue for us in our area. So we're looking in our area to try and we've recently applied for levelling up bid for £26 million for a new health and wellbeing hub to try and bring different areas of the community together. And that includes a 62-unit social care facility for older people. So we're trying to mix older and younger people together and try and improve their social well-being.
Okay, James, to you, how important is digital data and technology in the levelling up, productivity and change agenda for health and care?
Well, so for me, it's super important. But I suppose the argument is, how do we help others realize what those different levels of importance might be? Because at a time of stress, we need to be able to prioritize our efforts on the things that are going to make the most difference, the biggest bang for buck, if you like. In Health Education England, our responsibility is to think about workforce development, education, but also capacity, workforce planning. How do we get more people into the NHS? Health and social care accounts for about 10% of our entire workforce in England, roughly 50-50. Slightly bigger workforce in social care than in the NHS. And so trying to staff a service that is coming under more and more pressure over time is quite tricky. It doesn't necessarily take into account the fact, I think, that John will pick up later around public health and the fact that wider determinants of health are more impactful on the population's health than the delivery of healthcare services within the NHS. Nonetheless, at times of stress, we can address those issues through two things: more or different. And the more is, I mean, we know what health services are like right now. They are stressed, but we can technically provide more doctors, nurses, allied healthcare professionals, pharmacists, dentists, etc., and deliver more of the same services that we're delivering right now. The real attraction for different at times of stress is, in theory, you can do more with less. It's the efficiency and the productivity gains that you can make. And for a while in health services across the world, we've had something called a quadruple aim we've been looking at, which takes into account population health, as well as patient outcomes, as well as efficiencies, as well as satisfaction measures, both for patients and service users and also our own staff. And all of those together are things that we're trying to aim for. So if different is where, I guess, the most attractive options lie, more than 80% of different now is associated with delivering those services through digital means or partially through digital means. And that means we're going to have to invest more and more in digital data and technology services and in the staff to underpin them, which is partly the digital professional cadre, partly changes to culture and leadership, and partly digital literacy across the whole workforce. We think and we estimate in the NHS that means by 2030, we need to be recruiting about another 17,500 digital data and technology professionals into the NHS. So it's not a small job. So to come back to the question, yeah, pretty important, I'd say.
Yeah, absolutely. I think you've summed up why. John, why have we not made more progress on addressing health inequalities and levelling up?
Yeah, that's a great question. So we've known about inequalities for decades, if not centuries, and actually we've made very little progress on them, despite all the data that we've had. It's not to say we haven't made any progress. We just published a review of the cross-government strategies through the 2000s, and that made substantial progress in terms of narrowing the gap in life expectancy and infant mortality. I think there's lots of reasons why we haven't made more progress. We know what determines health. We've known that for a long time, and they tend to be these wider determinants of health. So it tends to be things like income inequalities, work, employment inequalities, educational employment inequalities. But I want to pick up two things just in response to that. One is, I think we need to do much more on linking the economic benefits of having a healthy workforce. When we close the gap in health between geographical areas and between socioeconomic groups, we get more productivity within the economy. And there's lots of data which have shown that. So I think that's the first point, is that we need to make the economic argument for levelling up health. And secondly, I think we need to articulate amongst ourselves our positive vision for the future. Health inequality, levelling up, has been about grievance and about unfairness, which lands well with certain parts of the population, but not with everyone. I think what we need to do is articulate this positive vision of where we want to get to, what good looks like in terms of leveling up and inequalities. And I think that will hopefully help change the narrative and create this positive for future change.
Okay, thank you. Tim, you work to increase the number of people supported by technology-enabled care or closer to home. How does that work? How is the NHS measuring up, and what more needs to be done?
Yeah, so thanks. So just to say, I'm really supportive of the previous comments, particularly around the quadruple aim and the opportunities that brings, particularly bringing in the staff benefit. So to answer your question, we provide funding to regions and systems to understand where they are implementing technology-enabled care to people in the home. So one really sort of good example of that would be the annual physical health check for people with severe mental illness. We know that people with severe mental illness are likely to die in the region of 20 years earlier than people without. And they're a cohort who generally may not engage as readily in sort of traditionally delivered health services. So one of the pieces of work that we've funded is around taking the elements of the annual physical health check, which are traditionally undertaken in a GP practice, and allowing that to be done in one location for sort of a dock-in-a-box type solution, which includes point-of-care testing to enable that service to go to people. And we've seen some really good results of that. One of the PCNs, which is supported in Greater Manchester, moved from only 19% of their people receiving the full annual physical health check up to 60%. So really good, significant increases. I think what we need to do is to continue to shine a light, recognise that these things can have a positive impact. The other bit, I think, is to recognise the benefit from seeking the opinions and views of those sort of seldom heard groups, because actually that leads to a lot of innovation that can have a really positive effect on service delivery to all people. So it's not just about going because because we should get to them. It's actually recognising there's some really good innovative service delivery models that can be developed and implemented as a result of looking at things a slightly different way. So I think we need to recognise the benefit associated to it. To John's point, it's a much more of a positivist, beneficial thing rather than a deficit-based argument. So.
Okay, thank you. And Richard, to you, can you give us a picture of Hertfordshire County Council? What's their current position? How are you trying to close the divide between deprived areas and the lack of medical support there and richer areas? Is Richard with us? Can't actually see that he is. I don't think he is. Okay, well, Richard can't answer that question because Richard is not here. Nick, let's go back to you. Tell us about this bid for a health and wellbeing hub. What are the main benefits? Just explain what that is and what makes that project unique.
Yeah, I think the main benefits of this health and wellbeing hub is that it doesn't aim specifically at sport and the traditional kind of way we used to think of things. It's very much arranged around bringing young people and older people together. So while we might have some of the traditional sports halls and a couple of swimming pools in there, we're also looking at things like community allotments, dementia-friendly sensory gardens, but also linking that to cycleways, BMX parks. So trying to gently bring everybody together, along with, as I said, a 62-unit extra care housing, which is probably the first time we've ever done that in South Holland. So that's giving older people a chance to look after themselves but get their appropriate help, but integrate the two different communities. So in South Holland, we've got kind of low wage, low skill economy. And it's trying to increase people's skills, give people a chance to talk to each other, but in a friendly environment, which is kind of non-threatening. And we hopefully we can get some medical practices involved in this as well. So lots of different ideas to try and bring people together, but to increase people's well-being.
Well, we've got a question kind of linked to that from Travis Smith saying physical inactivity has been a concern and a contributor to poor health for many years. Where would the panel suggest that investment should be directed to encourage the inactives to become more active? I mean, it's that classic, you can lead a horse to water, but you can't make it drink. Who'd like to take that question? Yeah, go on, Jim.
Yeah, so I think that's a great question. I think there's a few things to say there. So one is that we've tended to rely on this behavior change technique of trying to tell people the right things to do rather than creating the structures for them to do it. And we know from academic literature that just telling people what they should do doesn't really work very well. And for the people who it does work for, it tends to work for people who are more educated with more resource. So in terms of leveling up and physical activity, I think it's much more about how we create the structures within society to help people be more active. So that may be about how we think about local infrastructure to support people to be more active, whether that's roads and high streets, rather than thinking about how we tell people what to do better.
Yeah, well, James, the kind of second part of this question is, should public health services be more proactive in this area? If so, how? And as a sort of chief information officer, what would you say?
Probably. So I no longer work for a public health organisation. We work for an education organisation, but I'm sure that there are lots of things that we can do nationally. I can give an example of something that is particularly close to my heart, if you like. So, I'd be really interested in John's view on this one, actually. But one of the things that Maury helped us understand, that the polling organisation, is that the general public don't like it when central government has an adult-to-child relationship with them. When they're told to do something, as if they're being told off. We as adults like an adult-to-adult relationship with other people, including our establishments and our government. And so I understand what John's saying. You're not going to get as much uptake if you tell people you're fat, do more exercise, than if you put in place a number of things that enable them to do so. I come from a digital world. Increasingly, we use digital solutions to solve problems. That's what Moore's law tells us. Every 2 years, there's a doubling of opportunities around digital data and technology to solve humanity's problems at large. In this particular case, there are things to help people do exercise for fun that helps get them on the road. Give you an example. A few years ago, I backed a Kickstarter for a mobile phone game called Zombies Run. I don't know if any of you have heard of this. It's now into at least its 10th iteration. But you play it, you put it on your phone, you put it in your earbuds, and it's basically a couch to 5K game. But it appeals to those people who like zombie games. And as you're running along, you hear the zombies chasing you, and it makes you run a little bit faster. And actually, it works. And it went to the #1 spot in the Apple Store when it was released. In order to put some meat on the bones of John's point about infrastructure. So at the moment, we know that there is a skills deficit in our clinical workforce who do not regularly prescribe apps to patients, even if they're free, because they don't know whether they're good or not. And quite frankly, there are more than 500,000 health and wellbeing apps on the combined Google Play Store and the Apple Store. Some of them are extremely beneficial and have got demonstrable medical evidence base behind it. Some of them actually can cause harm. There was an app to help you diagnose melanoma, and it would misdiagnose a genuine melanoma as something you didn't need to worry about. That is causing harm. And there's a whole bunch that are somewhere in between. If we can somehow educate the clinical workforce within the NHS and social care establishment to help recommend those consumer apps that help encourage these sorts of activities, then we're likely to see us to start to chip away at some of these difficult public health issues.
Yes, go ahead.
Yeah, I would say one of the couple of important aspects here, one around social prescribing. I think that's a really important part of this. But as the previous speaker has said, it's got to be exciting, it's got to be fun. And I think one of the best ways is starting it very early on in primary schools. getting the parents involved. If you don't get the parents involved, you won't get the young people involved, and the other way around. So I think it's useful to be able to start them as early as possible. But dance, for example, of any sort of dance is easy, it's fun, and everybody can take part, and you can mix ages and abilities in that as well. So I think that's get away from the traditional sports side of things. That does tend to put people off.
Yeah, go on, John.
Can I just come back on a couple of those points? So I think they're really good and important points. So one is, I think we need to get much more clever about how we understand an individual's relationship with the state. So for people who've benefited from society, actually their relationship with whether it's a local authority, whether it's the NHS, whether it's a government, is often quite a positive one, where they're willing to listen to expert advice. But actually, if you've been screwed over by the bedroom tax and your welfare payments have been cut, actually you've got a totally different relationship with the state. And until we understand that relationship, that individuals, particularly those who feel that they've been aggrieved by the way society is and the structures within society, then we won't change their behaviour. So that's, I think that speaks to that point around personal responsibility and how we feel about being told what to do. The second point is, I totally agree with the opportunities within digital. The thing which frustrates me is that digital is often presented in this heuristic of a simple solution for what is complex problems. We think, digital will solve it. And how do we mature our thinking in the debate to think actually, digital will work really well and efficiently for lots of people, and we need to maximize and leverage for those people. Won't work so well for other people, and actually that's how we shift resource and time out the system to match resources proportionate to need.
Okay, thank you. Tim, let's talk about virtual wards. Tell us a bit more about them, how technology adds to the delivery model, and what difference they make to patients and healthcare professionals.
Yeah, so virtual wards are something that is not new in healthcare by any means, but what the real drive is at the moment is to understand, of the people who are currently cared for in hospital beds, how can the virtual ward as a concept enable them to get the same level of hospital level care outside of the hospital, thus freeing up hospital beds, but more importantly getting people home sooner where it's safe to do so. As we know, I don't think anyone who's had a night in a hospital bed can confirm that's probably less preferable than your own bed, especially if you're trying to recover and recuperate. So it's about providing hospital level care outside of the hospital setting. And I think the key element around a technology-enabled virtual ward is to be able to provide an extra level of sort of lens and insight into a patient's condition at any time. So these will often be either a technology which is worn by the patient, so a form of continuous monitoring, which will give information back to a dashboard, which will have some form of intelligent alerting on it, which would say, patient, so John is in his normal parameters for today. However, James seems to be out of those parameters, and therefore we recommend either a conversation with James or we understand what's going on in that space. So it creates an opportunity for us to prioritise, and also as health professionals, I've done a lot of sort of operational management. I've tried to understand around as a busy health professional or clinician, how do I know that I'm going to see the right person right now, or I'm prioritising care to the right people? So I think there's a real opportunity there. We also know actually from a staff wellbeing point of view that this sort of more of a blended career model where you can provide sort of what might be sort of time in a hub as opposed to being on the ward has a sort of a set of appeal to it. We also know, which is a sort of staff benefit, which I hadn't anticipated, is actually the virtual ward enables you to be fully focused on the person who's in front of you at that time, whereas when you're in the ward, your bleeper's going off, you've got to be here, can you just, there's a real sort of push and pull of you for various, so we know that patients also have got a really strong preference for it. So I think the technology brings that enablement to really focus on the right patient at that right time. And interestingly, actually, to the point before around exercise, I think some of the remote monitoring technology, whilst not probably appropriate for a population type approach, is helpful for those patients who are nervous. I've been in hospital, I've had some sort of cardiac related issue, some respiratory issue, how do I know that it's safe for me to begin having more activity in my life? And some of the remote monitoring can enable them to feel more secure in that space.
All right, thank you. James, in your view, is it more important to invest in technology or to invest in skills to reduce health inequalities?
Well, it all comes down to where you're going to get your most impact. In the context of this question, I think that's skills around implementing technology, and that's how I choose to interpret then, if that's okay, Samantha. But I definitely it's skills over tech. So for a while in the digital world, we've said that in order to implement digitally enabled change, you need technology, changes to people and changes to process. And it's the latter two of those that have the biggest impact. Otherwise, you end up introducing a whole bunch of technologies that no one uses to their full advantage. In fact, this has been proved really, really well in the States. In healthcare, we've got these things called electronic patient records. There are core backbone of information about patient information, the conditions that they have, the treatment they're on, and everything about them, really. It's our core information asset. And we have for a long time run healthcare systems on paper, of course, and we're in the process of digitizing them into these electronic patient records. About 10 years ago, the US went through a big central government initiative to try and get as many hospitals onto electronic patient records as possible. And it was noted that it was causing problems for clinical staff. They're spending more and more of their time in front of a computer screen and less of their time in front of a patient. So much so that one hospital put as the big advertising feature for trying to recruit new medical staff, we do not have an electronic patient record. Now, that is pretty damning. What that says to me is that technology alone does not solve problems. In fact, it causes them. You need to be able to change the ways in which your organization works. Or to John's point, you need to recognize that not every single service can only be offered by digital means. Digital can increase inequalities as well as trying to address them if it's not well implemented, not well designed. And we are, at the moment, trying to develop our health and care workforce by creating the educational products so that, firstly, you don't use technology where it's not appropriate to do so. Secondly, you recognise that you're offering services to everyone in your catchment. Public services are about serving everyone, not just the digitally literate or the rich. We are there for everyone, and therefore you need to make sure that you're able to offer services that do not unnecessarily skew equality. And finally, and probably most importantly, when we do create digital tools, you need to have the right skills to make sure you're buying the right ones or building the right ones, by which I mean they're designed with humans in mind. They help humans get to the end of the journey that they're trying to achieve as quickly and painlessly as possible. So definitely skills over technology.
All right, thank you. Nick, to you, I want to ask you about building cross-party consensus on health inequalities and levelling up. How do local authorities do that?
Well, I think they can do it relatively easily because I think cross-party, everybody wants to raise people's aspirations. They want to raise people's skills, and in I think they can see the bigger picture of by raising skills, raising wages, improving people's mental health. Then it does make a difference to your area, and I think it's important to involve as many people as you can. So it's not just about cross-party, but probably involving businesses, community groups, community organisations, and buying as many people into that as you possibly can.
Okay, thank you. John, last question to you. So we are out of time, unfortunately, but tell us what type of policies or interventions are likely to increase or decrease inequalities. Give us some examples.
Good question. So the first thing to say is that there's no silver bullet here. There's not a list of interventions which we could just take off the shelf and implement and go suddenly reduce inequalities. But there are guiding principles. We just published a framework which outline those. And if things like, when we design services which require less effort on the individuals, they tend to reduce inequalities. So if we design services which have lots of hoops to jump through, we know they tend to increase inequalities. Previous research on, for example, the health inequality strategy from 2000 showed that it required long-term multi-sector action rather than short-term siloed action. So, how do you build that long-term partnership program rather than short-term initiatives? We also need things like community engagement, which we've talked about. We also need to recognise that specific vulnerable groups need bespoke solutions. We can't just have the same offer to everyone. We do need bespoke solutions. And finally, we need this golden thread through everything, that we're allocating resources, whether that's staff time, finances, policy priority, according to need. So, we need to be constantly challenging ourselves to say, actually, through this policy, initiative, or service, are we allocating the resources that we have proportionate to the needs in the population?
Brilliant. Thank you so much. Really interesting to hear from all of you. Unfortunately, we are out of time. We could have gone on for much longer, but my thanks to James, Tim, Nick, and to John for your input on that fascinating discussion. Thank you so much.
Thank you.
And there they go. Well, we have covered a lot so far. It is time for another final break. We've got an opportunity to digest what we've learned in the last half hour or so. Our final break of the day, so it's your chance to engage with all the platform has to offer, whether this be our digital marketplace or the networking capabilities. We will see you back here in 40 minutes at 3:10 for our final session on housing. Thank you. I'll see you then.